February 25th, 2025. I'm Dr. Duke Majan, CEO and founder of Duke Spine Institute. It fell. And our patient here is coming to Duke Spine for back pain. She has back pain for many years. She's from Miami. She's had over 10 years of back pain. Turns out her back pain is coming from 2 discs that are damaged in her lower back and the facet joints on the right side at L4-5, L5-S1, and her piriformis muscle on the right. Now, when you look at her MRI, she's got 4 bad discs, but 2 of them are up here and they're not causing pain. Her pain is coming from this area here, this area here, and this area here. So she's got area 1, area 2, area 3. 1 is the 2 discs, L4-5, 5-S1. Area 2 is the facets on the right, and area 3 is the piriformis. Those are the 3 things we're going to fix today. We're going to start with the discs. Any questions, feel free to type them up. In the meantime, while we're getting into the disc, Henry, let's show the audience the 30 different causes of back pain. I'm Dr. R. Duke Majan with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The 4th most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, touches the vertebral bodies. With trauma, can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Machen. Thanks for joining us. To fix it. Welcome back. You can see there are about 30 different things that cause back pain. And Jordan, let's go with an AP view. I'm going to show you something. We have our needles in the two discs we're going to fix, L4-5, L5-S1 with the Duke laser disc repair. Those are the two discs causing back pain. But take a look at this facet joint over here on the right side. Yep, right there. That is full of arthritis. And I found that yesterday on examination. She had facet pain. We didn't know she had facet pain before she came here. We did an MRI review. We thought it was just the discs, but it turns out it's a disc and the facets. And so we're now fixing her facets. You can see from our video that the facet joints being injured are the second most common cause of back pain. The first is the disc. Disc injuries account for 85% of back pain. How is she doing?
Can you open your eyes for me? Good. We're going to ask you a few questions.
Where is she from? She's from Florida.
Open your eyes.
Yeah.
Good.
All right. She's had long history of back pain. Are you comfortable?
Are you having any pain right now?
All right. She's still just waking up. We're going to give her another minute while we're waiting. Henry or Brandon, what questions do we have? By the way, I want to recognize Brandon. Brandon is Henry's protege when it comes to broadcasting. Brandon is now helping Henry with broadcasts. Brandon, what questions do you have from the audience?
Yes, this is coming from Smarzik from YouTube.
Smarzik, YouTube.
What determines if you use a grabber versus the laser?
Yeah, so what determines if I use the metal grabbers to pull out pieces of herniation versus the laser? The grabber, I go grab pieces of herniation that are already loose and released. With the laser, I can release the pieces of herniation that are stuck to the annular tear from scar tissue. All right, we're just waiting for our patient to be awake enough. We're going to test those two discs and see if they're painful. We call this a discogram, and specifically this is what's called an evocative discogram because it's meant to evoke a response or no response. If the disc is not the source of the patient's pain, there will be no response. So if the disc is the cause of her pain, then there will be a pain response. Are you comfy?
How are you doing? You okay? Okay, good. We're going to ask you a question. Open your eyes. She said yes, she's comfortable.
All right. All right. How bad is that on a scale of 1 to 10? How high does it go? 10. I heard 10. Is that where you get your back pain?
Yes.
All right. So we just got 10 out of 10 at 4.5. Show us, folks, take a look at this x-ray. Jordan, show us the tear in the back of the disc where the dye is leaking out. The dye is the black stuff, by the way. We injected it in the middle of the disc. It should stay normally in the middle of the disc, but it's leaking out through tears in the back and front of the disc. The front tears don't hurt. The back tears do. And Jordan just showed you the back tear. That's what we're here to fix. Is that better? You having any pain? I can't hear what she said. Can you hear? All right. How bad is that on a scale of 1 to 10? 10? 10. All right. Is that where you get your pain? Yeah?
She said yes.
Okay. Well, we got batting 1,000 right now. We got two discs that were both 10 out of 10. One of them is really degenerated. The other one is well preserved but has a tear. We're going to fix both. You get to go to sleep. When you wake up, your surgery will be over. Those 2 discs will be fixed. They're definitely causing your pain. I want you to just lay still. Don't move your body. You can't move. Lay still. You're on the operating table. We're going to put you to sleep right now. I want you to count from 1 to 100 out loud. Count out loud for me. Count out loud. Count from 1 to 100. Have we made the incision? Yeah? All right. So she's going to sleep right now. The anesthesiologist, Dr. Berndes, is putting her to sleep with some propofol. And we're going to get started. I'm going to place the dilator. For those of you who haven't seen it, this is what it looks like, a long metal pencil. It's actually a very expensive metal pencil, over $1,000 for this thing. And it runs right down the guide wire. And we inject some numbing medicine through a second port on the back of the dilator. And that allows us to give the patient some numbing medicine as we go down through the fascia. We're heading down to the L4-S1 first. Now the L4-S1 on the MRI doesn't look too bad. That's why you can't rely on the MRI to tell you where pain comes from. The MRI will never tell you where your pain comes from, ever. Just I've looked at 500,000 MRI reports of the spine, and not one of them has ever said the pain is coming from this disc or this facet or this structure. That's because the radiologists have no clue. Structural findings don't equal pain. We know that because we've been doing this for many, many years, and we know that pain comes from structures, but the MRI doesn't tell you which structures cause pain. Man, there's a pretty good sized tear back there. Shot. Hold on. All right, take that. Take the guide wire. If you have questions, feel free to ask them.
We have a couple questions.
Go ahead.
First one from Karsten on YouTube says, when a facet ligament allows the facet to slip, that makes less space in the nerve channel.
Yes.
Does this mean that even a minor disc bulge will be able to create a lot of obstruction and pain?
Yes. Yeah, so the nerve channel is not the cause of the pain. The nerve channel can pinch the nerve and cause what's called radicular symptoms down your leg from a pinched nerve. Let me have a. Is that the same machine as the first case?
Nope, we switched it.
Switched it.
Yeah, just
That's fine. Yeah, of course. Yeah. Shot. So yes, when the facets slip down, it does narrow the neuroforamen, and it can potentially cause the disc to bulge out more, and it can cause the nerve to be pinched. That's very correct. That is a very good observation. And that's why people who have spinal stenosis that's significant in their neuroforamen or lateral recess, when they stand in extension, their radicular symptoms down their legs get worse. However, when they sit down, they bend forward, they open up the foramen, and their radicular symptoms get better. That's a classic finding in what's called neurogenic claudication. All right, let's see if we can find our mark. It'd probably be good if you somehow etched them.
Yeah, we have a different one that have it.
That's opposite, right? Yeah, that's the numbers. So we need to rotate 180 degrees. The tube that I use to do the surgery is not a round end. It has a fenestrated end. And the mark here on the tube tells me which direction is opened at. I'll show it to you when we take it out. All right, any other questions?
Yes, this is coming from Scott on Facebook.
Hi, Scott on Facebook. Welcome.
He says, where does the dye go after the pain check? Also, what is the dye made from?
Yeah, the dye leaks out the tear into the epidural space. Your body absorbs it. As a matter of fact, the patients, when they go in the recovery room after surgery, they get up and pee before they leave. Their pee is blue. So the dye gets absorbed into their bloodstream, and then it goes out their kidneys and into the toilet. All right, so are we ready?
What is this? Good?
The other question you asked, what is the die made out of? It's a vital die. We call it the Duke Spine die. I can't tell you where we source it because that's a secret. But we don't make it here.
Thank you.
All right. Very nice. So once again, the L5-S1 disc, which is the first one we're treating right now, if you look at it on the MRI, it looks pretty darn good. 99% of doctors would ignore this tear. They would ignore the L5-S1 disc. They would not think that it is the source of the patient's pain because it looks good on the MRI. It looks really good. But why did I choose to treat it? The reason is simple. A, it was damaged and bulging, but that's not enough. The fact that the disc is bulging and damaged is not a reason to treat it. It's because the patient pinpointed her pain exactly to the L5-S1 disc. Literally, I said, where is your worst pain? And she stuck her finger right there. So I knew from experience that L5-S1 is the second most common disc to cause back pain. Second, after L4-5, which she also has an L4-5. Then I asked her, what about higher up at L3-4 and L2-3 where you have herniations? She said, nope, I have zero pain there. So because of that, she has zero pain there. I said, we don't need to fix those discs, so we're going to leave them off the menu. We're not treating them. We're only fixing the ones that are painful. Look at this tear right here. This blue stuff is the herniation. The white stuff is scar tissue within the annulus. Are we good? Scar tissue right there. You guys see that? Inflammatory scar tissue. That's
Yes, we
where
do.
all the pain comes from, that tear. I am the one who figured out that this tear is the cause of back pain from a painful disc, and I'm the first one in the world to actually go in and repair it, and I use a laser to do it. We can't do this without the laser. Just see how well the laser works. Somebody asked, what if you use the grabber? Well, let's just use the grabber. The grabber doesn't do much. It grabs out little pieces of loose herniation, but that's not the whole problem. The problem is the tear and the fact that it needs to be cleaned. But these are little pieces of herniation stuck in the tear. So that's what the grabber is good at removing, are loose, unattached pieces of herniation. Any questions?
Yes, we have one from Pawnlust.
A what? One from Thomas?
Pawnlust.
Oh, Palmless.
Yes.
Very nice to hear from you again.
Yes. Pawnlust says, is there anything to fix the end plate irregularities and modic 1 changes? I likely caused some end plate irregularities with intense physical activities, and a year later, one of them has modic 1 changes. It's an area with pain, and I've even seen some suggest oral antibiotics for it.
Yeah. Well, Palmless, first of all, you're never going to fix modic changes. Nobody is. Number two, you don't need to fix modic changes. They're not the problem. Okay? They are not causing any symptoms at all. All of our patients have modic changes. Modic 1, modic 2, modic 3. And that is never fixed by any of our surgery, yet we take their symptoms away 100%. That's because the modic changes are not the cause of symptoms, so do not treat them. You don't need antibiotics to treat modic changes. I would forget about that. There's a lot of nonsense out there, folks. It's sometimes hard for you guys to, of course, you can't possibly know what's nonsense and not nonsense, but I do. That's because this is what I do every day. I treat these conditions. Antibiotics have zero role in treating disc pain unless you have an infection in the disc called discitis, which I literally see that once every 10 years. That's probably 1 in 250,000 patients. It's extremely rare and unusual, and we don't see it. It almost always happens after a botched surgery like a microdiscectomy or laminectomy, or some type of an injection where the doctor used a dirty needle and got infected material in your disc. But we don't have that happen at Duke Spine. We've never had an infection from these surgeries. Antibiotics have zero role in treating modic changes. and modic changes do not need to be treated to get rid of people's pain and symptoms. Any other questions?
We have another question from Lance on YouTube.
Sure. Welcome.
Lance asks, can an annular tear fully heal itself after a herniation has been removed?
Can an annular tear fully heal itself after the herniation has been removed? It will not heal itself unless you have this procedure called the Duke laser disc repair. Having a microdiscectomy where the surgeon goes in and removes a herniation will not allow the annular tear to heal itself. Your annular tear will not heal itself because there is no debridement that is done of the annular tear. You must have a laser debridement, endoscopic laser debridement like I'm doing right now of the annular tear for it to heal after the herniation is removed. The reason is simple. The surgeon is not removing all the herniation. You see this blue stuff here I'm removing? That is literally 0.5 millimeter, 0.5 millimeters. That is blocking the annulus from healing. And I'm removing it with the laser because I can see it. When you do a microdiscectomy and you remove a herniation, you cannot see these small pieces of herniation stuck in the annular tear because they can't see all the way down inside the disc. I used to do microdiscectomies. It's impossible. And I have the best microscope in the world that you can use for a microdiscectomy. So my point is, having a microdiscectomy or a discectomy will not allow your annulus to heal, period. Because the surgeon is not doing a Duke laser disc repair. That's why. This is the only surgery in the world that allows your annulus to heal. Nothing else does.
We have another question coming from Scott on Facebook.
Sure, Scott.
Scott says, have you read any of the PubMed articles on giving patients L-glutamine IVs before leaving the procedure to speed up the healing by 40%? It seems like it could make a tremendous difference if it was an a la carte offering.
That's a great suggestion. Thank you for making that. So the suggestion was, have you read any papers on offering L-glutamine to patients as an adjuvant to their treatment to speed up the healing? So here's the thing. Glutamine is an amino acid, right? That's my understanding. Glutamine is glutamic acid. L-glutamine is the isomer, left isomer of versus R of glutamic acid or glutamine. You get amino acids from your diet. You don't need to do IV glutamine. It's just another, in my opinion, so far without reading the papers, and I am a scientist, so I'll reserve my final and full judgment to after I read it, and I will read it, by the way. Thank you for bringing it up. But my first feeling or impression is, why do you need IV L-glutamine when you can just have protein? Just go have a chicken breast or have a can of beans or something. There you get your glutamine there, or have a piece of fish. Okay? You don't need special IV glutamine. By the way, the nerve root's going to be right in that fat there. You're not seeing it because there's fat. But we just cleaned out the tear. You guys see it? There's still a little bit of a tear there. It's about 3 millimeters. That tear will heal. The body will heal it because I just removed the herniation out of the tear. If I didn't take the herniation out of the tear, it would never heal. But the herniation must be removed with a laser. There is no other way to do it. Those other doctors that do spine surgery and take out the herniation, they're not taking all the herniation out. They're not taking the part that's stuck in the tear out. The only way to do that is to use a laser, and they don't use a laser, so they're not doing it. How do I know? Because I used to do those surgeries all the time for many years. And that's why the reherniation rate is so high with microdiscectomy, because the tear is not healing. Okay, give me that. I want to show them the fenestration. You guys see this?
Yes, we
At
do.
the end of the tube, right? You guys see the fenestration there?
Yes, we
It's
do.
not just a circle like at the end. It's actually fenestrated. It allows me to view this way. I told you I'd show it to you, so I'm showing it to you. Okay, so far one disc done. We're moving on to the next one. Any other questions?
We have a question from Charlie on YouTube.
Charlie on YouTube, welcome.
What caused you to utilize an anterior approach for cervical DLDR rather than the transforaminal approach?
There is no transforaminal approach for cervical DLDR. Transforaminal approaches in the cervical spine equal removing bones and ligaments that you need to get to the foramen. Why would you ever go to the foramen? The problem is not necessarily the foramen, it's in the front. It's where the herniation is, at the back of the disc. You can't get there transforaminal in the cervical spine. It is impossible to get to the back of the disc through a transforaminal approach in the cervical spine. Nobody in the world can do that because the spinal cord is in the way, and if you cut through the spinal cord, you're going to paralyze the patient. So let nobody tell you differently. Transforaminal posterior cervical surgery is garbage. It's what they were doing 100 years ago, and it should not ever be done. It's destructive and dangerous and unnecessary. The truth is, surgeons that do spine surgery, if they're not able to do the best, they shouldn't be doing spine surgery. That's my opinion. I spent the time and money to be the best, and I don't do things half-assed, especially when it comes to people's health. Neither should they. Right, Berndes? Can you imagine if we do half-assed anesthesia? We'd be killing like 1 in 10 patients. Now, for some people that's okay. Maybe if you live in certain countries you can do that, but not in my book. There are, believe it or not, lots of surgeons who think it's okay to have complications. There are a lot of surgeons who think it's okay to have bad outcomes for patients. They think it's okay for patients to not get better. I don't believe that. I think if you're not going to help the patient get better, you shouldn't be doing the treatment. So, long story short, there's the right way to do these surgeries, and surgeons should learn that, or they shouldn't be doing surgery at all. There's no excuse. These procedures, we've published them multiple times, and they're in the peer-reviewed published literature on PubMed. Anybody has access. I publish them in open source free journals, Surgical Neurology International, for example. Anybody can see that without paying any money. So my feeling is if you're not going to provide the patient the best type of surgery, you shouldn't be offering them surgery. All right. Any other questions?
We have another question from Pawnlust on YouTube.
But before you do that, look at this piece of herniation here I'm pulling out. It's hard. Like I'm trying to pull it out through the scope. I can't. It's got so much scar tissue, it's banging against the scope. And it's not coming out. It's got very much scar tissue because it's been under the influence of inflammation for many years. Now I'm going to say it. This disc, L4-5, is different than the one we just fixed. L5-S1, the first one we fixed, was soft. It was a soft herniation. The disc was well preserved. This disc is more collapsed, more degenerated. This disc was injured a lot longer, like before, like probably 10 years ago, maybe 20 years ago. But the L5-S1 was injured more recently. So maybe a few years, maybe a year or two. As a matter of fact, she may have had like this disc causing her back pain for 10 years, and then in the last year, the L5-S1 got hurt and herniated and started causing pain, and maybe that's why she finally decided to do something about her pain, right? Because everybody has a tipping point, right? So you might have pain from one disc that's tolerable and bearable, but then you get a second disc causing pain, and it pushes you over the edge. And you're like, this is too much, 2 discs causing pain. By the way, the average number of discs that cause pain by the time I see patients and do surgery is 2.4. That's 2.5 basically, 2.4 discs. So it's not 1 disc. Maybe people with 1 disc that's painful that can tolerate the pain and they live with it. But By the time they come to me for surgery, they have 2.5 discs causing their pain. It's just an interesting statistic if you think about it, for a lot of reasons. One, everybody thinks there's one disc, the worst looking disc on the MRI. That's the one you have to fix, and all my pain will go away. Well, that's not true, because the average patient has 2.5 discs. So if 2.5 discs, then you better start looking for another disc, right? Because the average patient has 2.5 discs. The vast majority of our patients with disc pain have 2 or 3 discs that need to be fixed. Those 2 or 3 discs are the cause of their pain. Only 8% of our patients have 1 disc that's causing their pain. 8%. That's less than 10%. Less than 10% of patients that have chronic back pain have 1 disc that's causing their pain. The vast majority, 92% of patients, have more than 2 or more discs, basically, 2 or more discs causing their back pain. This is based on analyzing 5,000 patients with debilitating back pain at our clinic in the last 5 years. That's not every patient, but it's the ones we had the data on. All right, any questions?
Yes, coming from Pawn Lust on YouTube.
Sure. Sorry.
If you send herniated material to the lab, isn't C. agnes overgrowth common in degenerated discs?
No.
I've heard
Absolutely
that.
not. Palm lust is asking if there's a bacteria that is growing in the discs. The answer is no, it's not true. I don't believe that.
We have a comment coming from Pawn Lust on YouTube. I am also not convinced that collagen supplements work since they're still broken down by stomach acid.
You're right. Palm lust, you're right. Collagen supplements. So you bring up a great point, right? Collagen supplements, you're trying to build collagen. By the way, so palm lust is thinking on multi-planes here, multiple planes. What he's saying is this tear right here, when I'm done cleaning it, the body can heal it. And what it heals it with is collagen and elastin, mostly collagen, okay? Your body heals these tears with collagen. So what some people say is, okay, if I take collagen supplements after surgery, my tear will heal better and faster. But collagen, like every protein polymer, is broken down into individual amino acids in your stomach or your gut, basically your small intestine. And those amino acids are then absorbed into your bloodstream, distributed throughout your body. And those amino acids are then used to repair the disc. So what Palm Lust is saying is, if you take collagen supplements, they're not going to stay as collagen and be absorbed as collagen. Collagen is a polymer of amino acids. It's a long chain. It's like, if you're playing with Legos, it's like a piece of Lego that has 100 bricks on it. And your body can only absorb single bricks. So that 100 brick polymer of Legos is going to be broken down into individual Legos before it's absorbed into your bloodstream and used by your body. And he's right. He or she is right. I don't know who Palm Lust is, but they are correct. Biochemically, your body breaks down all proteins into single amino acid, and that's how you absorb them through your gut. So taking collagen supplements is not going to give you more collagen necessarily, but it stands to reason that it could, right? After all, you have now the amino acids to build collagen. Look at the top of the scope. See it? See the bubble? I think that's a lens issue. Not you, Henry. Sorry. I'm talking to my team here who loves breaking my scopes. We got to do something about this. This is the last warning. Today. If I still see this, I'm going to make some changes. If you're not going to make the changes. I can talk to you about it, explain it to you later if you call me, so you understand it.
Yes, sir.
You understand?
I understand.
Sometimes when people are angry, they manifest their anger in certain ways that you may not realize that they're manifesting it, But when I start looking at things happening around that shouldn't be happening, I start to realize there must be a reason for it, right? And I won't tolerate that kind of behavior. It's unprofessional. Uh-huh. All right, we're just about done. We're going to end this stream in a moment. I'm going to grab that piece. What the fuck is going on? Any other questions?
Yes, we have this next question coming from Spicy Irwin on YouTube.
Spicy Irwin.
I love that
It
name.
reminds me of Steve Irwin. I love Steve Irwin.
As we all.
I hope everybody had an opportunity to watch Steve Irwin.
Oh, of course. Not live, but definitely reruns. But Spicy Irwin asks, I had a foot and laser surgery for spinal stenosis, which pod doctor thought it was a neuroma. My question is, because there was no neuroma, is that why my foot burned and blistered by laser?
I don't. I'm so sorry. I have no idea why your foot burned and blistered. You know, we don't have that problem at Duke Spine, but I have a feeling I know. It could have been a thermal burn. It could have been a reaction to a medication. I honestly don't know. Without more information, it's impossible for me to speculate. I don't like speculating. So I can't tell you why, but I don't know why you had burning and blistering. If I had more information about the treatment and, you know, pictures and stuff, I might be able to tell you. All right, we're all done with the disc. We're going to bring you back in a few minutes for her facets. So restream will start in about 2 minutes.